therapies that are coming out of the forefront? What are some of the promising things that you're seeing in research right now that would be game changer for patients that suffer from lung cancer?
We're still trying to do a lot of work on early detection. What we really would love to see is,
once again, to Medical Success Secrets. I'm super excited about my latest podcast interview. Welcome to the podcast, Dr. Eugene Manley. How are you doing?
hello, I'm good. Thanks for having me today.
Well, let's get into who you are and what you're about. So everyone, you don't know Dr. Eugene Manley Jr. He's an inspirational speaker, educator, and information magnet. The author speaks about STEM careers, navigating academia, workforce, and clinical trial diversity. He's really about overcoming barriers, health equity, and really helping mentorship in the future. He's the founder and CEO of STEMM and Cancer Health Equity Foundation based in New York. Their organization looks to increase STEM workforce diversity and improve outcomes for underserved populations navigating the cancer care continuum. He is a mechanical engineer, biomedical engineer, and molecular and cell biologist and biochemist with 20 plus years of experience in using systems, biology approaches to understanding musculoskeletal biology, biomechanics, and cancer biology. He transitioned to the nonprofit world and worked at the ACR, LCRF, and longevity and role spanning strategy development, grant administration, STEM outreach, mentorship, and training, program development, and science communication. Dr. Manley has also done 11 publications and has given more than 60 presentations across different mediums. He partners with others to advance studies on disparities in lung cancer, patient advocacy, and community engagement. Dr. Manley, this is a great introduction of who you are and what you're about. So thank you for joining this podcast. So what we need to get into is dig deeper into this. Health equity is a big one, but cancer health equity is specific and is really eye-opening when you dig into the numbers. For instance, according to the National Cancer Institute, Black men are twice as likely to die from prostate cancer than non-Hispanic white men. And Black women are more likely to be diagnosed with breast cancer at a later stage than white women and almost 40% more likely to die from it. Can you walk us through the problem that's happening right now when it comes to cancer health equity?
Well, those numbers are very similar in lung cancer. We see that there's a lot of lung cancer females that don't smoke, and they often are eligible for screening. We see that Black patients often are diagnosed later, at later stages and earlier ages. And we see massive disparities in how they receive and access care. So it's a universal problem across cancer, not just lung or breast.
When you kind of think about this problem and how the social determinants of health is becoming a buzzword in our industry, right? Even now, the organizations I talk to, independent doctors and multi-specialty groups, there's new reimbursements around helping patients navigate certain scenarios around their illnesses, right? To kind of help lessen that disparity. But when you kind of talk to organizations and do speeches, what are you seeing as successful in helping to fight cancer health disparity when you talk to organizations?
There are a couple of things. One, we still know that lung cancer is only about 6% of the screening eligible population is screened. So recently at the National Lung Cancer Roundtable Workshop, it may be implied that we're missing some data, so it may be as high as 18%. But either way, it's still much lower than colon, prostate, and breast cancer. The thing we try to educate people about is that we do now screen, generally still have to have a history of smoking or have quit within the last 15 years. We try to make sure that providers know. We do know that some programs where thoracic surgeons train primary care physicians about lung cancer screening eligibility and their nurses, then they get higher uptake of screening by their patients. And the other point that is around policy is in January, I believe, they just announced the rules that nurse navigation is now billable as a service. And that is really going to drastically change how we provide access to patients. Because before, it was not a line item, so hospitals couldn't really put it in the budget. But now that you can bill for it, it'll help make nurse navigation play the critical role that it does in helping those patients navigate those difficult questions.
Principal illness navigation is a huge opportunity there. That's the reimbursable code that was announced, like you said, in January. And healthcare, just like anything, right? Incentives change behavior. And so now you have financial incentives that are driving this up. This is helping nurses and other healthcare organizations kind of create programs to help patients navigate the complexities of cancer diagnosis. I want to kind of talk specifically your drive for lung cancer specifically. There's prostate, there's breast cancer, there's tons of different other kind of cancers are out there. What is it about lung cancer you feel like, has an opportunity that we can solve or at least help that disparity a little bit faster maybe than other cancers?
Well, lung cancer is interesting because it is the second leading cause of cancer death in the US and worldwide. It has the least people know about the treatments that are available. In lung cancer, specifically since 2003 and the discovery of EGFR, lung cancer has driven a lot of the precision medicine that we're seeing. Right now, we have about 10, maybe 11 different biomarkers for lung cancer, and they have different therapies, targeted therapies. We also have some immunotherapies. And before 2003, the only options were chemotherapy and radiation. But now with these options available, we can extend lives of patients. However, many patients still aren't getting the full suite of biomarker testing. And most likely, they're only going to get 1 to 3 biomarkers tested. And so when you don't test all the possible biomarkers, you're leaving potential therapies on the table. Some providers still don't know that we have comprehensive and next-gen sequencing that can identify these things. So that is also presenting some issues. So we're still trying to get the word out about these tests. But the flip side of these tests is that there's still a cost to them, and it still impacts the most underserved patients the most. Lung cancer just driven a lot of the therapy development that we've had in the last 15 years, and it's actually increased the survival rate of patients with lung cancer.
A lot of pulmonologists, right? So COPD is a big issue there for them, but also respiratory diseases. Obviously, we went through COVID, and that was a huge driver for a lot of innovation. Now, lung cancer being a piece of that, definitely this could help. Could you deep dive into the EGFR, understanding that and what that specifically? We're familiar with work nephrologists, so kidney disease, right? Understanding those measurements there. How's that helping with lung cancer diagnosis, understanding those numbers for patients?
Well, specifically, if you can test for like EGFR, KRAS, ALK, then we know there are specific therapies, sometimes first, second, or third line therapies available for these patients. Sometimes the downside of these targeted therapies is that the tumors may develop resistance, and then you have to go to the next line of therapy. But that is sort of sometimes a catch-22 with these targets. But tumors are, we can't take this pressure, so we're going to get around this block, and then we'll make another way to keep growing. But now the primary option for late-stage lung cancer patients, I think another indication just came out recently, but I don't know it off the top of my head, so I don't want to misstate it. But we've done such a great work in the development of therapies, so just making sure that everyone can get them access.
Therapies are coming out of forefront, right? What are some of the promising things that you're seeing in research right now that will be game changer for patients that suffer from lung cancer?
I think we're still trying to do a lot of work on early detection. Some people are trying to develop blood-based biomarkers, circulating tumor cells. They're still in the air how much they're going to work. What we really would love to see is an early detection test in the blood that can suggest if you have lung cancer, and then you can come back and follow up with lung cancer screening. If we ever had something like that, that would completely be a game changer, because then we could catch cancer even earlier and then increase survivorship across the board. But we're not there yet.
Researchers trying to figure out that early detection in the blood, and that would be extremely helpful. So I totally understand that. As we talk to organizations now, and they talk to patients, obviously prevention is a big thing, right? Yeah. How do you stop smoking, smoke cessation programs, things like that? At the individual level, internal medicine, primary care, what things can doctors do at that level, right, to kind of help change behavior in patients to remove, smoking and even vaping? I see a lot of people vaping saying that's better, but we know statistics say that's not as safe as we think it is. What are some of the things that you've seen be successful programs that help patients kind of pet out smoking, or at least, lessen the harmful effects?
I know the University of Chicago, Illinois Medical Center, they have a great community engagement program where they've been speaking to the community about lung cancer screening and the needs of smoking cessation, and it's been successful. You mentioned something else. You mentioned the vaping. That's going to be, I can't completely say, but I'm almost confident to say that we will probably start seeing many more lung cancer cases from those in the next 10 to 15 years. Because, it takes time for all those mutations to set in. The problem with vaping, people think it's better because you're just not smoking a cigarette, but it's actually even worse because there are even many more carcinogens in those chambers. And now you're aerosolizing the air, and now it's going directly in and it's heated up So it's directly depositing and it's getting deeper into the airways. So we don't even know all the chemicals that are in those vaping cartridges. And just like they did with cigarettes in the Black community, they're putting these flavorings in them, and that's just making them more addictive. So it's going to present some issues down the road, and we just don't quite have it in screening guidelines unless an org writes their lung cancer screening guidelines to include those factors in it, which can be done.
When you're kind of thinking about your expertise in this area, right? I know you started out as an engineer. I actually was an engineer at one time and then went over to the business side, went more into the research side, right? And then the biology side of everything. But if you kind of think about like promotion and advocacy for health disparities and putting out the messaging out there, I know you're pretty active on social media. How is that helping build awareness? Do you see active social media in this fight helping change public perception around lung cancer, and more importantly, helping to raise awareness, problem, and how it can be solved?
There have been some great campaigns that have been done recently. I think it was Intersect did a Save by the Scan campaign. I think there was also a National Lung Cancer Screening Day campaign. And there's a group in California. I've just drawn a blank on their name, but I think they had a website, Screening Saves Black Lives, or Black Screening Saves Lives. I'm so mad that I can't remember the name right now. But if social media is used effectively and you present the information factual, accurate, but from a community and you're trying to engage lens, it is more likely to be accepted than just throwing the pictures of the people coughing. And like, cause I see a COPD commercial and that triggers me, but maybe also because I grew up as a chronic asthmatic and I was in the hospital 20 to 30 times a year just with my asthma. And so those commercials, I don't like them at all. I understand what you're trying to say, but there are other ways to get the message across. So a lot of times what we do in lung cancer, we also now try to make sure people know that while smoking is one of the leading risk factors, anyone with lungs can get lung cancer. So we have people that don't smoke. There are other risk factors like indoor cooking modules, living by freeways, chemical plant exposures, toxic air pollution. Just think of people that live by areas that have a lot of forest fires. Just think of all the particulate matter. So there are many other risk factors. And the other flip side of that is there could be a person that smokes every single day of their life and never get lung cancer. There are some people that only smoke once, and there are some people that just don't smoke at all. So you just never know. While it's a risk factor, you just do the best to try to minimize your exposure. But we know the campaigns in the 80s did a great job of getting people to stop smoking. But the downside was it used sometimes such demonizing, triggering language that now today people think that, oh, if you get lung cancer, you had to have been a person that smoked, and then you get demonized for this, and it's like, that's not the case.
I remember those, especially the drug ones, right? This is your brain on drug. Forget some of the more frightening ones. Oh yeah, they had that one about the smoking and the young lady had the hole in her throat. I think that was like, yeah, and that was like, wow, that was like powerful, right? And so it kind of changed the generation to kind of think of smoking, negatively. Obviously, my parents' generation, I think that was one of those things they just did to be cool. Now they started to kind of get away from that in the 80s and had those, like you said, really aggressive marketing techniques. Now we're in a different era, right? We don't be as aggressive, but more that soft kind of influence when you see on social media. And to your point, get to know people, like people, and trust them, individuals who have similar backgrounds and things of that nature. And so having culturally relevant language that speaks to you and your time and about what's important to you. Do you think influencers help at all, like social media influencers or celebrities, that impact behaviors when it comes to awareness or change behaviors?
I don't know if it so much can impact behavior, but I think when at least the famous people talk about that they were fighting a cancer, it humanizes it more. Now, some people may disregard them over their famous person talking, but if they are getting the awareness out about the disease, I think it's helpful. Influencers can and cannot help. It just depends on what they're trying to influence. And you can have a presence and reach without necessarily being an influencer. Like, I wouldn't say I'm an influencer, but my content just says, how do we help people navigate disease, learn about STEM careers, learn about outcomes, where can you find resources? So, but you can use these voices to amplify what you're trying to do. I think that can be effective, but don't solely rely on that. I still grassroots community engagement, going to schools, going to churches, going to the farmers market, where people live, not just the same standard places.
Also, I forgot that other area that you work in is also STEM education, mentorship. So if you kind of look at practices, medical doctors who kind of have their own practice or they work in the hospital and they want to get into research, what's that path for them, right? Is to start into research in these cancer areas. What have you seen be successful? Obviously, those who start out that way and go down that path in academia. What if you're already in private practice or working as an employee? What are some pathways to kind of start if you're very passionate about research and get into that area?
So if you're in, I guess, a practice or a hospital system, it'd be best to then partner with someone in there that already is doing research, or find a Ph.D. or other researcher that can help you and partner with you to develop your strategy and plan, because you don't want to haphazardly do studies and then you have to question, are you trying to do a clinical trial or basic research? There's a whole different spectrum of things. Basic research is starting with cells and then possibly animal models, but then if you're doing clinical trials, you have IRBs and other things that you have to really be prepared and know how to navigate. And you can't just jump and say, I'm going to do X. You just have those real deep discussions, figure out what you want to do, and then see if it's rational and possible. Then there's grants for it. Sometimes pharma has investigator-sponsored trials. And so sometimes these are for trials on one of their therapeutics. Sometimes it's a trial on one of their therapeutics and use they're not using it in. So you just have to check for those. But if you're at a bigger place, typically they have a grant office, or you may need a grant admin. But trying to apply for NIH grants, it is cumbersome. I'll say that.
Ensure you have a plan to go after it. I work with a lot of healthcare organizations, smaller practices, multi-specialty groups looking to get into clinical studies. There's opportunities there. Academia, we know there's tons of opportunities in academia, but some of the smaller practices. What I've seen, a lot of the underserved populations, it's just hard to get them in those academic settings. And if you have that local PI that understands that patient populations, can recruit them easier into these studies, I've seen that be a lot more successful. Have you seen that strategy work when it comes to getting that diverse?
Trial diversity has been a big issue for a long time. They released a new FDA updated guidelines that said trial providers have to have a diversity plan. But what it didn't do is really only applies to phase 3 trials. It does anything for phase 1 or phase 2. And it doesn't really say what your barometer is for recruitment or success. Like, you could say your goal is to increase your enrollment by 50%. But if that 50% is going from 1 patient to 2 patients, have you moved the needle at all? There's really no penalties for not making your mark. And so no one's really being held accountable. It's at least an effort to get boards to look at the diversity of their trials. Now, that being said, when you mentioned a good point, that many of these places, they still go to the academic centers to try to do trials, but these places tend to not have diverse representation, and they don't have often diverse doctors. The staff don't reflect those patients from underserved groups, and then the patients go in there and don't feel seen or heard, or they still feel stigmatized and isolated, so they don't want to engage. So we have to do a better job of educating the clinician workforce on how to engage, work with underserved populations, and how they can treat them with respect, and don't just show up when you want to do a trial. If you only showing up because you want to do a trial, but you've done no other work to build trust, to build camaraderie, to know those people, it's not going to happen.
Insightful. And so hopefully a lot of medical practice who we talk to, and doctors and owners, but more specifically, those who have passion for this work, get involved more to change that dynamic. I mean, we saw it during the pandemic, right? They were struggling to find diverse candidates for a life-changing, vaccine that was really going to help everyone get back on track. So we work with some candidates and practices of clinical research organizations on remote trials, because that makes it easier to kind of help patients, get engaged, right? A lot of patients, especially in underserved communities, just don't have the resources to get back and forth to trials, do all the things they need to do, and still live their life. And so having a way to make it easier to get into trials that they can help, not just access, but also accessibility. So those are some of the things that we're kind of looking at. But Dr. Manley, this has been insightful, also interesting. What are you working on now that you're promoting, and anything that you want to talk to, our specific?
I want to mention 3 things. You talk about people being interested in cancer and cancer disparities. The one meeting they should check out should be the AACR conference on the science of cancer health disparities. Next month, it's in LA this year. If you want to see a group and a room full of people that are really doing work from basic translational clinical community engagement, that is your meeting to go to. I think it's 4 days this year. They have poster sessions. It's like one of the best disparity meetings anyone can go to. And it's across the board, across cancer. The other things that we are working on, one, I run the STEMM and Cancer Health Equity Foundation. Our mission is to increase STEM workforce diversity and to improve, like you said, outcomes for underserved patients navigating cancer. One of the ways we're trying to do this is by trying to improve health literacy. What I saw growing up in Detroit as a first-gen scholar, and even to this day, a lot of families, you go to the doctor and they'll say, well, this is in my chart. Patients don't understand my chart jargon, and I'm getting asked to translate stuff. So one thing we're trying to do is working to create a bunch of general medical infographics and some general cancer infographics to help break down this complex jargon so that those that have the least access or underserved can actually understand it and see it represented from their lens. So we'll hope to start pushing those out early next year. The other big thing that we are working on is our second Lung Cancer Health Equity Summit that will be held in Atlanta on November 18th and 19th. The theme is Black and Latino populations navigating lung cancer, stepping stones to equity. And the reason we put this summit on is we wanted to bring together stakeholders from all levels, patients, caregivers, researchers, public health, clinicians, surgeons, government, policy, insurers, and payers, and nurses present and talk about solutions and interventions that they have developed that actually decrease disparities, decrease inequities, and/or improve outcomes. So it's a conference focused on solutions, not just the problems. If you want to learn more, the registration page is tinyurl.com/LCHES. So that's the registration page.
Put that in the shop. Everyone, if you're interested. So definitely this is something that is going to be in the forefront for the foreseeable future. So Dr. Manley, thank you for your time today. Appreciate it. Looking forward. Everyone, thank you for listening to this podcast. Again, if you have interesting ideas about innovation, technology, especially in healthcare, please check out our latest podcast, go to our YouTube channel and see all the latest information. Thanks again, Dr. Manley, everyone. Have a great one.
Thank you very much.